Okay, so good afternoon, everyone, and welcome to this session on primary healthcare and NCDs. We are going to discuss the potential of digital solution to address this new rising burden, disease burden in Africa related to NCDs and how this relates to primary healthcare. My name is Hani Iskander, and I work for the International Telecommunication Union, and I'm leading the work on ICT applications. And I have a distinguished panel of speakers who I will introduce one by one. Needless to say that the rise of the NCD worldwide is quite alarming. More than 60% of the deaths now are related to some sort of an NCD. And the Africa region is not an exception. What is specific about the NCD is that it doesn't really differ between the poor and rich. Everyone is impacted. I think we all, with this new lifestyle and the new way of having the way we eat, the way we move, we are all affected by some sort of an NCD potentially. By NCD, we mean those type of diseases like cancer, diabetes, respiratory diseases, cardiovascular diseases that are very much impacted by human behaviors, and they are very much linked to lifestyles, essentially on the way we work, the way we move, stress levels, etc. And the good thing, or the good news about them, that they are in some extent avoidable and preventable if we address the risk factors. The main risk factors are related to diets, physical activities, tobacco, and also the use of alcohol as well. So without further ado, I'm going to hand over now to my colleague, Prebo Barango, who is the NCD focal point for Eastern and Southern Africa at the World Health Organization in the WHO Regional Office of Africa, to kind of provide some insights about the status of NCD in Africa and what is WHO is doing to address this. Thank you.
Thank you very much, Hani. Distinguished panelists, ladies and gentlemen, it's actually my honor to be part of this event. So Hani has succinctly summarized what NCDs are. And the key thing I want us to take away from this is that NCDs have emerged as the most important cause of mortality and morbidity globally. In 2015, NCDs accounted for about 40 million of the total 60 million global deaths. When we're talking about NCDs, although there are other NCDs, but the key NCDs that are responsible for these mortality will be cardiovascular diseases, cancers, diabetes, and chronic respiratory diseases. So these four, they share modifiable risk factors. Modifiable risk factors are risk factors that I like to say that we work hard with our hard-earned money to acquire. This includes tobacco use, harmful use of alcohol, physical inactivity, and unhealthy diet. So in a nutshell, those are the risk factors for NCDs, and those are the key NCDs. Now, the topic we are talking about is NCDs in the context of universal health coverage. The way the health systems has been developed has been that it's for acute events. So you have malaria, you go and see a healthcare provider, you are treated for malaria, they do the test or whatever needs to be done, and you go away until you have another episode. But NCDs are chronic. They are long-term. So the health system needs to change its orientation in terms of managing NCDs. Having said that, when we're looking at universal health coverage, we're looking at what services are covered, we're looking at the cost of this coverage, we're looking at who is covered. those are the key things that we look at when we are talking about universal health coverage. Now, for NCDs, therefore, we are going to have to design interventions that cover the spectrum of prevention, early diagnosis and treatment, palliative care if needed, rehabilitation. So when we're looking at universal health coverage in the context of NCDs, we have to think about provision of all these services. Now, there has been several global commitments on this, reducing the morbidity and mortality from NCDs. Key among them is the 2011 political declaration on NCDs that led to the 25, I like to call it 25 by 25, the commitment by all heads of states to reduce premature mortality from NCDs by 25% by 2025. 2015 was also another year that we had important milestones for NCDs. There was the Sustainable Development Goal, which Target 3 talks about a 30% reduction in premature mortality from NCDs by 2030, so the 30 by 30. So all these commitments needs to be achieved, and to be able to achieve them, WHO has actually come out with what we call sets of best buys, and best buys are interventions that, irrespective of the socioeconomic status of a country, you can afford to implement. So you can't say because you are a low-income country or you're a high-income country, you cannot. The best buys are interventions for NCDs, and they cover prevention and management. The prevention looks at tobacco use, interventions to curb tobacco use, alcohol, harmful use of alcohol, diets, unhealthy diets and physical inactivity. Also looks at best buys for cancer, HPV vaccine for hepatitis B vaccination, for hepatitis B virus and hepatocellular cancer, as well as cervical cancer screening. We've also recently included HPV vaccination for pre-adolescent girls. So all these interventions are interventions that can be implemented within the context of preventing NCDs by any country. In 2013, there was a landmark in the prevention and control of NCDs. There was a collaboration between WHO and the ITU. I heard yesterday too that we have high mobile penetration in Africa now. Mobile penetration, the growth of mobile cellular network and use of mobile phones is actually has actually outstripped population growth rate. I'm sure everybody here has at least one mobile device, and you should please check in case yours is not here. You probably left it in the taxi or in the hotel. So everybody has a mobile device. So in harnessing the use of mobile technology for NCDs, there was a collaboration with ITU, and we had the Healthy Be Mobile initiative. This initiative is looking at taking advantage of mobile applications for NCDs prevention and control. And so far there are 3 toolkits that we've published for the 3 interventions that are currently being implemented in Africa. This will be the diabetes, which is looking at using mobile technologies for prevention and control of diabetes to ensure proper management of diabetes. This has been it's currently being done in Senegal, and we also have the cervical cancer. Cervical cancer is currently being done in Zambia. And the whole idea is that, I said NCDs are chronic, so there's also a component of the patient's responsibility and responsiveness to treatment. So he needs to be able to access treatment, but he needs a lot of education to be able to do this. So that's the Be Healthy, Be Mobile that we are implementing. In Senegal, we've done the diabetes, like I mentioned, and it was actually evaluated last year, and it was found that using mobile technology, it was a cost-effective way of improving management of diabetes in people that have diabetes. We also have the M cervical cancer. The M cervical cancer is currently being done in Zambia, like I mentioned. And the whole idea is to be able to empower women. Now, the recommendation for screening of women is that women 30 to 49 years old should be screened at least once in their lifetime for cervical cancer. Cervical cancer is a low-hanging fruit. In most developed countries, the incidence and the prevalence of cervical cancer has reduced. In Africa, it has not. And the reason is because most women are not able to access services for screening. It doesn't require high-tech to screen. For the early cancer, it doesn't require high-tech to treat. The primary health care, it can be done at lower levels. So the whole idea about the M cervical cancer is to increase coverage of screening. I will stop here and we can continue the next round.
Okay, thank you very much, Prebo, for your notes. I would like to move now to Ms. Frezia Karua, who is the General Manager of Amref Health Africa. We all know, or at least heard about Amref and the great work that you are doing using particularly digital tools. So if you can share with us experiences and what you have been doing and what are the lessons learned. Thank you.
So thank you, and it's a pleasure to be here to discuss this very important topic and to see how we can leverage technology to actually save lives and definitely effectively manage NCDs. So Amref Health Africa is an NGO that has been in Africa for the last 60 years and initially started as flying doctor services, but now we operate across 35 countries in various programs, including NCDs. And when you look at the NCD problem in Africa, it came in when we still had our communicable diseases, as epidemics that we are trying to manage. And so the system, as we said, was not supportive of that. But definitely there are lessons that we can learn from management of HIV and TB so that we can actually leverage on that. So in Amref, we have our NCD program that leverages a lot on technology. It's rightfully been said that mobile technology has penetrated Africa significantly. And so Amref, being largely a capacity building organization, has leveraged on mobile technology to train especially community health workers and first-line health workers in prevention, so education to the community, as well as screening and referral of patients with non-communicable diseases. And so, therefore, trying to bridge the gap between the household and the formal health sector. And so using mobile technology, we are able to train community health workers on the various NCDs and how to identify them, how to educate households on prevention, and those that already have the NCDs are then educated on how to stay healthy and to keep going for their medication, as well as continue with the self-management that is required. We also use mobile technology to collect data at the household, and this data is also around the self-management aspect. So daily, or at least every 2 days, checking on their blood sugar, random blood sugar. If it's a BP check that the community health worker can carry out. And so that data is then linked to the DHIS to be able to then inform the health system. And then we also have the mobile technology supporting supply of medicines, so enabling the facilities at the primary health level to forecast the medications required for the community that they serve. as well as looking at demand-side financing. And this is mainly community-based health insurance, or for the countries that have the national health insurance. Then we're able to use technology to enable households to save and therefore pay for their premiums or even access services at a fee-for-service if there's no available insurance. And then, of course, the community health worker, like they did in the HIV and TB program, are able to remind patients to take their medication and to remind them to go for checkups. And so the idea here is to use community health workers as well as the mobile technology to achieve 100% treatment adherence. And of course, direct messaging to the patients and the households as well as the family members. And so Amref has this mobile technology called LEAP, which is a platform that trains community health workers on various topics, including NCDs. And so they have virtual learning that's on demand. And we're able to therefore evaluate them, give them quizzes using gamification. And therefore, they're able to actually acquire this, this training and get a certificate that allows them to then provide services at the community level. It also, allows them to have group chat, and this is the very basic analog phone that operates on 2G. And therefore, they're able to have peer-to-peer collaboration. And you also have a digital, record of what the community health worker has achieved, what they've learned, how they've performed. And so you're able to then, plan what to do with the program as far as training is concerned. And then, of course, we have the digital platform that collects household data through the community health workers or even the community nurse. And this enables, the health system or even the facilities that the patients are referred to once the community health worker visits them to know where to then what to order, for example, if it's drugs or if they need further follow-up, then this data is used for that. And then it's linked to the DHIS system. Then we have the third mobile technology that I've mentioned, where we have community health workers helping households to save for their healthcare services. And when you talk about UHC, it's really about access and, of course, financing and creating equity. And so when you look at what we're trying to achieve is to ensure that a household, while talking, while engaging a community health worker, not only has access to information and referral, but also can start saving for healthcare, to access whether it's the NHI or even the community-based health insurance. And the community health workers, because they are not paid, earn a commission. And so this creates a system that allows them to be, somewhat remunerated for their performance. And so one of the things we've done with this technologies is then put them together in what you're calling points of care or even community pharmacies, where you have the technology that trains and educates, you have the diagnostics, and then bringing in the telecom partners to provide connectivity, because as you've heard, there are many areas in our continent that you don't have connectivity. And so those are some of the things that we're doing at Amref, and I'll stop there. Thank you.
Thank you very much, Frezia, for this overview of the work of Amref. Now I would like to move to Dr. Nao Sipula, who is the CEO of a company called What If Health, based in South Africa. And Dr. Sipula has been involved since a long time in providing digital solutions, particularly at the community level. So we'd like to hear from you about your experience. Please.
Good morning, everybody. Good morning, everybody. It's a great pleasure for people like myself who come from the private sector to be associated with the kind of work that we're presenting today. Needless to say that when you're coming from the private sector, it's a long and very lonely journey to travel, to try and solve problems that are of a continental nature. But we come from the private sector, and what if health, as the name says, what if? We have approached the issue of non-communicable diseases in a multifaceted and more integrated approach. Most of our innovations for mobile technology are aligned with SDG 3 and the need for meeting universal health coverage. I need to take some time and take you through what we are actually facing when we're talking about NCDs. NCDs are not the same as HIV and AIDS. When you compare HIV and AIDS and NCDs, HIV and AIDS is a walk in the park. NCDs have changed the game. And whatever we do today in order to address them, whatever technology we bring, that technology, I always say, will never be a game changer. It can only level the playing field because NCDs have changed the health game. The NCDs come in and find that for centuries, healthcare has been centered around primary health care as the foundation for providing universal health coverage. But that system has been structured to deal with acute diseases. It gets confused and gets lost once you introduce non-communicable diseases. Now, this is the problem. And when you look at this, you'll understand where we are and where we're going. And no country has ever succeeded to successfully fight obesity in children and adults in the past 30 years, irrespective of where you come from in the world. And in South Africa, by 2014, 70% of South Africans over the age of 50 years were suffering from hypertension. This is the highest ever blood pressure reported by a national representative survey for people over 50 years. That's very significant. And that's what we faced with. So when we look at universal health coverage and we compare ourselves globally with Europe and compare ourselves with North America and Asia, you'll find that they're doing better because they've got deeper pockets. And they spend America spends 75% of its health dollar on managing non-communicable diseases. Europe, by 2013, was spending about 70 to 80% of their healthcare euro on chronic diseases only. Africa can never afford that. Whatever technologies we bring, there's no way Africa can be able to afford that kind of budget where we take 70% and 80% of our health dollar and spend it on NCDs. The point I'm making is we're sitting with a problem where we will go to the rest of the world, cap in hand, asking for aid to treat diabetes. And that's bad news for Africa. Now, we looked at the problem from a private perspective. I'm a medical doctor and I've been practicing for 30 years. I've got a very basic understanding, but very good understanding of where the problem is, where we are, and where we're heading and how we should be structured. The problem that Africa has is a beautiful problem. Actually, I love it. I tell people that I love Africa's problem. Africa hasn't got a problem with resources. Our problem is how to allocate our resources properly such that we can spread it across all of us and be able to attain universal health coverage. Now, we identified 3 problems that Africa is having, which are good problems. We don't have sufficient health workforce. This is a problem globally, wherever you go in the world. The health workforce keeps on declining year on year. That's the first problem. The second problem that we're having is that non-communicable diseases are complex. They are, as you might all know, When you have got diabetics, you need a diabetic specialist. When you've got hypertension, you need a cardiologist. When you've got high cholesterol, you need an endocrinologist. Africa does not have this. That's the second problem. The third problem is the one that I mentioned, that you have got a primary healthcare system that is leaning more towards acute diseases. Now comes to where we are coming from private. We say when we innovate, let us innovate for that problem, because it's a nice problem to innovate for. We are not settled with payment systems that have been feeding this animal called NCDs with a lot of interest groups. Now, when we innovate to solve this problem. We solve it very simply. Actually, it's not a very difficult problem to solve. We have got a lot of community healthcare workers that we trained during the HIV and AIDS period. You remember? Those were doing home-based care. Now we innovate to give them tools that will turn them into healthcare workers. In our application, in South Africa, we've got about 50 clinics now that are running, and they're run by nurses. But nurses work as though they are doctors, because we have, and then we go to each and every one of those clinics and convert each and every one of their receptionists to work as a health assistant and not a receptionist, because technology can help us to do that. So we give them a tool that helps them to work as nursing assistants. And then we upskill the nurse so that the nurse can work like a doctor, because technology allows you to do that. And then the good thing with that is that it allows us to get doctors to operate as though they are specialists, but one doctor covers something like 20 clinics at any given time from a remote location. I cover 30 clinics. Every morning when I wake up, before I come here, I look at my referrals, I write prescriptions, I open files, and I order bloods and I order tests. And then by lunchtime, I'm going to have a look at them and order all the changes that are necessary, because we can be able to do it in real time. That solves the problem of the lack of a health workforce. And when we innovate specifically for that. And we target that, and we hit it very hard, and be very ambitious about it. The second thing that we do is that there is no knowledge, as you have seen, of NCDs on the ground. Even if when you go higher, it is in silos. So we innovated and say, because I'm a medical doctor, as a generalist, a family physician. So I understand how those silos operate, because each and every one of them, when I send patients, they reply to me. So I understand how the silos are connected. So we took ICT and destroyed those silos, okay? And took that information that is at tertiary level, brought it down and gave it to the nurse. Now, once you do that, there is less and less requirement of specialists. And then a specialist will support, I don't know how many doctors, but also at a remote location. The good thing about NCDs is that when you have got an NCD, when you've got all the data, all the information, all the clinical information, short of a doctor seeing your face, you don't need to see a specialist. We can send the specialist the file rather than send the patient. And that's what we have innovated for. And that solved our problem for the problem of lack of knowledge. So we took that knowledge and brought it down to primary health care. Now, our applications are not similar to what you call electronic health records. These are high-impact clinical applications that think like a doctor. And then we design them as though, as the first, I would put it as, we designed them as the first attempt at artificial intelligence in primary healthcare. Now, how scalable is this? You will see, to scale it, you need a community healthcare worker, you need a good laboratory service, a nurse, and web connectivity. And then in the background, we learned from other industries that we can create what is called a call center for chronic diseases, where, and I call this chronic disease virtual war room. In the virtual war room, we're able to manage a program of chronic non-communicable diseases from a virtual perspective and supporting big numbers of clinic and giving them specialist support at any given time. Our business model, it's a very simple business model. We provide these applications to government, NGOs, private clinics, and patients. Each and every application that we provide is free. All we do is we charge for training, system maintenance, support, and upgrades. You can see it requires support and upgrade because it's a knowledge system. You cannot give it to and license it to anybody or making it open source, because at any given time you require specialists to interrogate and review the treatment protocols, treatment guidelines, and new information that comes into medicine. I think I'll stop then. Thank you very much.
Thank you very much, Dr. Sipula. It was interesting to know that you love African problems. So that's a good news. And you also said that they are easy to solve, which is another good news. So let's proceed. So now I'm going to move to Mr. Harold Nasser, who is the head of Novartis Social Business. And we would like to hear from you, Harold, about what a private pharmaceutical company like Novartis can contribute in this discussion about primary health care, universal health coverage, and NCD. Please.
Thank you very much. I think, is that working? Yes, now it's working. Thank you. My name is Harold Nasser. I'm heading Novartis Social Business, and I took the journey just for this occasion to be here on stage because from my perspective, decentralization of care to the community level is close to my heart and very important. Now, let me contract with you that I take you on a mental journey now, together with me. If you had, in your earlier ages, if you had dancing classes, most likely there always was a shortage of guys, right? So somebody was missing at the party. Now, and I think the persons missing at the party here is the private sector, in the way that the private sector can actually try to find business models, long-lasting business models, which are scalable, to spot and help overcome market failures and system failures. That sounds easy, but it isn't. Let me share with you what we in Novartis bring to the party, and let me reassure you, we have learned our dancing steps, and we are dancing to the music of the public health system. We have, for example, designed according to that business model concept, social business model concept, meaning that we do not want to generate a surplus, and if we do, we reinvest that. The Novartis Access NCD program intervention, it's based on a portfolio of medicines, of 15 essential medicines on the commodity side, and on the other hand, to contribute to work within the health system on capability and capacity building interventions. Secondly, for more than 10 years, we are engaged at the community level in remote places in India and now also in Vietnam and Kenya with a community-based education program, which is, because at the same time there's also a selling component, which is breaking even. That means it is scalable and replicable. And then, of course, it's not only the NCD and the community space where we are active in, but our unit is also responsible for the Novartis malaria program. So until today, we, for example, shipped more than 815 million treatments at cost of our anti-malarial drug and saved many, many people's lives. So for us, the big question is how can we bridge from a vertical intervention in the infectious disease area into a more horizontal and community-based approach that we can learn from each other's side. And how can we engage in smart partnerships, in smart dancing combinations, where we need to mutually learn from each other. How we behave if the guy is turning left, then the partner might also want to be turning left. Now, let me share about a digital program that was very much linked to the anti-malarial commodities. At local dispensaries, of course, we were always facing shortages of supply. So on a cell phone basis, the SMS for Life program was co-created with Vodacom and IBM and Novartis at the time and launched in 2009. By today, that program has reached more than 10,000 public facilities in countries like Tanzania, Kenya, Cameroon, Ghana, the DRC, for example. And we have also signed MOUs in Kaduna, Nigeria, and in Zambia recently. What that program does is to help monitor stock level movements, and of course not only for antimalarials, it can easily be expanded to also cover NCD medications, and of course not only from Novartis, but from other companies as well. It also, that type of intervention, which I think is very concrete and has been proven independently from a monitoring and evaluation perspective to work, it has helped to increase the availability of medications in rural, remote dispensaries. It also brings the opportunity to monitor the surveillance of the patients, adherence to treatment, and improvement of the conditions, so that it can help inform the health system on the utilization of NCD medications. And last but not least, on a smartphone basis, it can easily also provide training courses, training programs, which have been developed and can further be developed with the public sector so that we indeed work within the system. So to cut it short, there is a very simple solution in various countries already which can be scalable, and it doesn't have to be this one. We are always happy to contribute with other partners with the knowledge, the experience that we have made, and come to the party. Thank you.
Thank you very much, Harold, for those insights. Last but not least, I want also to move now to Florence Godry-Perkins, who is the founder of the Digital Health Partnerships. Florence, you've been one of the early advocates, and you continue to be for digital health, and you've been involved in so many activities. So we'd like to hear from you as well some words of wisdom, lessons learned, and sharing what you are doing now. Thank you.
Thank you, Hani, for your kind introduction. So let me begin by saying I'm very happy that this panel is here and that I'm also part of it, because I started getting involved in digital health in 2010. And digital health for NCDs in particular have been sort of the core of what I've developed over the years. And what happened is I entered a group called Alcatel-Lucent in 2010, which does telecom infrastructure. And on our desks every morning we were receiving statistics on the mobile penetrations rates in Africa. And I happened to be someone who was very interested in global health. So the combination of that, when I saw these statistics, I thought, oh my gosh, the world is about to turn upside down. And I got so excited about the possibilities that this would bring for, basically a better access to health in lower and middle income countries in particular, where we still are faced with major infrastructure and human resources problems. So that's how my story started. And then I met a diabetes doctor in Paris right around, I think, 2011, 2012. And she was explaining to me the problems of amputations in Africa, which are horrendous, which is one of the things that happens when you have diabetes for a while. And also, she explained to me that 80% of these amputations has been proven in Europe can be avoided. And she proceeded in then explaining that it's not that difficult to avoid these amputations. There's some very simple advice. So the combination of the digital with that, we actually presented a project, won a prize for it, and this is right around the time that Be Healthy, Be Mobile was getting created. And I was very excited about that because I kept also saying, my gosh, there's not enough links between the world I was in, the ICT world, and the health world. A lot of bridges needed to be built, still do actually. So having ITU and WHO cooperate sort of made me really, really want to support them in that. And that's sort of what gave the seed to the M Diabetes project in Senegal. So Prébo, you mentioned, and I'll just add a couple of things perhaps to it, since I was also quite involved in that project from the start. In fact, Alcatel-Lucent at the time provided the software as a service platform that was used to send the SMS. So the project's actually reaching 117,000 patients this year, of which there's about 8,000 health workers. It's fairly simple because it's a one-way SMS, but what's exciting is a monitoring and evaluation was just done, and it's about to get published, so it's not even completely official yet. But it showed that even with a simple tool of sending SMS messages to help them, well, either prevent or curb the disease or simply manage it better, they achieved 0.3% of reduction in the A1C levels in the first 3 months, and an additional 0.2% the following 2 months. So that's exciting because there are much, much more sophisticated tools, if some of you participate in the last session, that exist today, whether it's AI or whether it's a connect devices to your phone and everything, that have shown, of course, better results. But even with simple tools, we're now proving that it can really have impact. What happened then is I developed a similar project in Mexico. Mexico is much bigger than Senegal, 120 million, so it was more ambitious. And here I thought, I always focused, I wanted to scale digital health because back in 2010, we already had pilotitis galore in digital health. So I thought, oh, wait, if we bring the Ministry of Health, the Ministry of Communication, e-government, and private sector, and the local ecosystem, and basically build what I call a bus, I'll come back to the story of the bus afterwards, that will scale digital health no problem. And that's kind of what we built in Mexico. So there were groups like Alcatel-Lucent, of course, now Nokia, Sanofi, AXA, the health insurance world is extremely important. I'll come back to that, Qualcomm. And we brought in the Inter-American Development Bank, who seed funded the project. Where we stand on that project is they've done a POC, 7,000 patients in 7 states in Mexico. And the hope, we're waiting now for the new president to be elected in July, which is holding things up a bit. But there's enough of the right partners around the table to hope to then move to a scale of this project. I've since left the Nokia group and created, as Hani mentioned, the DHP, Digital Health Partnership Organization. And I've had the great pleasure in the realm of that adventure to work very closely actually with the Novartis Foundation. I see that Anne Ertz is here. Thank you for being with us, Anne. And it's been a privilege to work with them because we're actually very, very aligned from a philosophical point of view on what needs to happen in digital health, but also because they happen to be very focused on NCDs and digital health as I am. And they're in fact working in a number of countries doing extremely disruptive, innovative programs using also digital health in Ghana, Senegal, Vietnam, Brazil, and Mongolia. And what they're doing also is really disrupting the system in the sense that people are getting diagnosed like in barber shops, in nail salons and everything. So they're working on both the health systems angle, but also using digital tools to back that up so that patients can actually be followed up on. This also brings me, I was talking about buses earlier. After a while, when you build these projects, you realize that's not the only answer to scaling digital health, because what we're missing is the roads. This goes back to a report that we talked about yesterday on a session on governance and leadership, on the need for governments to really get involved now and build the roads, which I won't stay on this, but that has to do with interoperability, building common digital platforms, building the right regulatory frameworks, and of course the whole human resources component, which is very important. So the Broadband Commission, I don't know how many of you are familiar with it. They just met actually the spring meeting on Sunday. We are now working on a second. The last report was very successful and impactful. It's a great advocacy platform that really hits at high level, so it's a great platform to use to raise visibility. And last World Health Assembly, what really was one of these aha moments, because as a digital health champion, we live and breathe this stuff, and we think everybody is aware and everybody realizes what the potential is and the great things it's going to do. And so last year, the World Health Assembly, there were about 50 events on NCDs. And, oh, this is great, because one number that hasn't been mentioned yet, Prébo, you mentioned 67% of death are on NCDs in LMICs, right? The one huge problem is that only 1% of the health funding today for global health goes to NCDs. So not only do we have the problems that we all evoked, the lack of infrastructure and human resources, but we have a huge problem also on the funding on NCDs. So this is where I think digital health is really, really, really going to be important. So going back to WHA, 50 events. I didn't attend all 50, it wasn't possible, but many of us, interested in the subject did. Nobody was talking about digital health. Nobody mentioned the word innovation. So this spurred us basically to say, okay, we have to do something at a high level advocacy, and this is what the slides that you see up here, this is the next digital health working group report of the Broadband Commission we are working on to try to raise visibility, in fact, on the potential of the immense potential, I believe, of digital health on LMIC. So you see there are a lot of people involved. It's very exciting. I think you see the World Health Organization, the World Bank, the African Union, many private sector companies and governments, as well as development banks. And this report should be released in principle in the margin of the United Nations High-Level Summit on NCDs this September, and we're all very excited about it. And I should mention that the co-chairs, there's always co-chairs in these working groups, is in fact, again, the Novartis Foundation and Intel, and which is great because, again, you're merging the ICT world with the health world, which is so important. And perhaps I'll stop here, honey, because I think you wanted to move the... now, just maybe a couple of more things. To rebound also on what Harald was saying. On this report, we're pretty deep into it already, right? We don't have the final outputs. But one of the biggest nuts to crack, and this is on digital health, in fact, in general, not only related to NCDs, is the business model that you were just referring to, Harald. Because where we are in the cycle of digital health, as you're seeing also in Africa, a few projects that are really scaling now. Take Mom Connect in South Africa, which has reached, for example, 2 million patients. A lot of these projects, of course, it's working along with government, were funded initially by funders, people interested in digital health. The problem is that this has a limit. You start reaching 2 million patients, and the money runs out. There's an operational cost, including actually paying mobile operators for connectivity costs. And so it's extremely important today, and we're going to spend quite a bit of time in this report looking into this. And there's some good innovative models coming out. One last thing, because we do have in the title of this panel, universal health coverage. There's something very important about that, that we're going to dwell on this because there are some models and we're starting to see the needle turn a little bit, is that the health insurance world in the ecosystem of digital health is kind of the last one to wake up, to be honest. Pharmas have woken up to it a little bit later than the ICT world, that's normal. But the health insurance world, when they really get it, when they really understand the return on investment that digital health will bring, this is when the needle will really, really turn. So we are going to cite many examples of some of the early things that are starting to happen across the world on that, but I wanted to make a point of this because it is so linked to universal health coverage. We're not going to achieve universal health coverage without digital health, and certainly this whole NCD equation, in view of the numbers that we've given you, it's extremely important that we do focus on that and realize the importance for that particular subject. Thank you.
Thank you very much, Florence, and for all the panelists. We still have 9 minutes to go, so I would like to open the floor for questions or observations, remarks, if any. So we have 4 already. So let's start with the gentleman here. Yes, here. Just raise your hand, please. Okay.
Good afternoon. Thank you very much, Chair, and thank you very much, panelists. I think that was very insightful. I could relate to the first presenter because he talked very much about Zambia. I'm from Zambia. My name is Yesewad. I'm Director Comms. Director Communications, so I'm in charge of the ICT sector. It seems to me that probably I'm the odd one out here. It seems that most people here are doctors. The question that I have, I think, has been echoed briefly by the last speaker on scalability. I've spent all my life in this sector, ICT sector, and I know that it presents a potential, in fact, for most of the problems that we face today. We can literally resolve a lot of problems that we face. But sometimes there is lack of understanding for the things that we do. When I listened to the doctor from South Africa, and he spoke about the business model. First of all, there is a component there. It says it's free application, but there's then the cost of maintenance and everything else. To me, it's still not free. But the question then comes in of the total cost of ownership. We're talking about a sector that is very sensitive. We need to understand the total cost of ownership. Talking about scalability because the software can be expanded is not enough. In the expansion, in the expansion of that solution, there's a cost associated with it, and sometimes it's so exponential. It grows as much as you add clients, and then it becomes more expensive. And we can't have a system that whose cost just increases every time you add an application, then it increases. Every time you add 2 patients, it goes up. It's unsustainable. So sometimes the talk of scalability is only focused on the technical application in the fact that it can be scaled, but not in the change management, because we need to change systems, and most of them are inefficient. And we sometimes have to also look for money. It's also part of scalability. And there's so many other things that you can talk about in the scalability. And sometimes that lack of understanding of the scalability, or in fact, let me say total cost of ownership, is what worries me when people talk about solutions in the health sector. I thought I should just make a comment. I don't know whether somebody would like to comment back on that one. Thank you so much.
Thank you very much. Let's talk other questions, please.
Thank you so much. My name is Sulakshana Gupta. I work with a company called Viamo. We work in mobile engagement. I was very interested to hear both PPPs and simple mobile technology mentioned on this panel. And I actually want to talk about a solution that we've now managed to scale to 17 countries in Africa and in Asia. This is called the 3-to-1 model. It's a public-private partnership with the leading MNO in the country who provides free calls through a short code and makes public service information available to the population. We have this already in Rwanda. It's the 845 service. It gets an average of 1 million calls a month, and it's a partnership with MTN, and there is already a volume of health information available. So I think from the demand generation, behavior change, communication side of things, this is a really scalable partnership where telcos and the public sector and mediating organizations such as ours can really make an impact. So in the context of NCDs and creating more awareness, getting people to access healthcare, we think that this is a solution that can be really effective. And we've proven the scalability now in 17 countries. So, I would encourage you to look at viamo.io and viamo.io and basically read up about the 3-to-1 service. And I'd be happy to speak to any Rwandan colleagues here who's interested in learning more about the 845 service in Rwanda with MTN.
Thank you very much. Let's take other question, please. Professor Kibiki.
Yeah, thank you very much for all you speakers. You are addressing really a very important subject that is relatively new for Africa, but is going really to have a major role in all what you are doing in health. I wanted to hear a little bit more from the WHO. How much is this in Africa? Because the figure, the 3/4, which is the death that is due to non-communicable diseases, is global. Now, how much is this given the fact that we're still grappling with the infectious diseases and other conditions? But on the other hand, also wanted to make comments to one or two. That one, we have to look at non-communicable diseases in Africa. They are not the same as non-communicable diseases in the Western world. They are setting in a terrain that is completely different. And even the risk factors really are not exactly the same. So even as we plan how digital technology and solutions are going to help to this, we have to be cognizant of these facts. And we have really, to me, is that we have really to see how much these solutions and technology will be there at the community level and be able to pick these conditions early. There are a lot of unique situations that are so specific for Africa. You mentioned of cancer, for instance. There's a so-called Southern African belt of cancer of the esophagus, which up to now we don't have clear answer why it's specific only from Ethiopia all the way to South Africa, only the eastern side. The western side is not, and the rest of the world also is not, with the exception of Iran, somewhere there to a bit of China. We need to know all these. So we really needed to have these solutions focusing on the community. The other aspect which we have also probably in bracket to consider as non-communicable diseases, HIV is still there. So the current status is that we have to use ARVs to suppress the virus, and that's it, we can cure. Which means for life, people will be using ARVs. These are new drugs, so which really, there's a lot that we don't know. So to me, because when you take a medication, something foreign in your body, you don't feel good. It's a disease by itself. So ARV is a disease, and it will be there for life. So to me, in bracket, this is another non-communicable disease, which we have to start thinking on how to address, not only in terms of compliance to the medication, but also the long-term effect that may come, whether it's going to add more to cardiovascular diseases or to kidney diseases or to diabetes, but by itself is also a condition. Thank you.
Thank you very much. We can take one last question, if any, and then we'll move to the panel. Okay, so last question.
Hello. Thank you to the panelists. It was really a great conversation that we really needed to have. My name is Maili Gasakre. I'm from Team Heart Rwanda. And it was in regards to, I just wanted to kind of know what really was done in cases of stockout. We talked about anti-malaria stockouts and something like that, but it was not very clear in the cases of NCDs, for example, because we talked about the fact that I work mostly in the cardiovascular diseases area, and we have a lot of stockouts, for example, but there's nothing that can respond when there's no infrastructure to help that digital health that's already put in place to know, even though the NCD nurse or the community health worker tells you or texts you, or I don't know the platform that you're using now, that we don't have, there's a stock out of certain medicine that the patient needs to have. How do you get it to them? Even though you have the question, how do you respond towards that care that is needed immediately?
Okay, great. So maybe let's go with this order. So maybe we're gonna start with you, Prebo. There was a question about the status of NCD in Africa. So if you can highlight this, please.
Yes, thank you very much. There was also a comment or a question on how scalable the mHealth interventions are. And there are quite some, I'm going to share some best practice that from the countries that we've been implementing. The first one is start simple. For Burkina Faso, it was a simple one-way SMS. For Zambia, the cervical cancer, we started with a one-way SMS system, and we are scaling it up now to be a bit more responsive so the clients can, but we started simple. That's the first thing, start simple. Two is there needs to be political commitment. To sustain this, there needs to be the highest level of government needs to be committed to scaling this up. And associated with that, it needs to be part of the overall health strategy. It shouldn't just be a vertical program. If it's part of the overall health strategy, for example, when Zambia was developing their national cancer control plan, it coincided with when the mHealth for cervical cancer was going to be introduced, so it was part of that strategy. The advantage of including it in the national strategy is that If it's in the national strategy, it might be costed. There might be funds available for it. But if it is not in the strategy, it's zero chance of having any funding for it in terms of sustainability. And also, the third or the fourth issue is about cost. For cost, we actually have some innovative financing for NCDs using what we call the syntaxes. And this can be pulled in for these interventions. For example, for tobacco, WHO recommends the Empower strategy, which one of the core part of it is to increase taxes on tobacco. Same thing for alcohol. South Africa is about to introduce taxes on sugar-sweetened beverages. This extra funding can be pulled in to mHealth and digital interventions for prevention of NCDs. Because for a long time, Ministries of Health end up subsidizing these industries. Because when you have NCDs, the government takes care of the bill. So that's one in terms of sustainability. In terms of the burden of NCDs in Africa, key challenge we have is with data. That's one. But we know that some cancers, for example, cervical cancer in Africa is about 800,000, the prevalence. For cardiovascular diseases, it's about 300,000 people mortality. Those are key ones. It's also further compounded by the fact that in African region, our own definition of NCDs is slightly broader. So it includes mental health disorders, it includes violence and injuries, it includes eye and ear disorders. But another key thing with NCDs in Africa is that premature mortality, meaning people that die before 70 years, is most prevalent in Africa. One of the slides I wanted to, I can share those informations. You'll see that all countries, most of the countries in Africa, it's all red. Younger people are getting NCDs at a younger age in Africa, and they are dying at a younger age. When I was in medical school, the teaching was that, for example, type 2 diabetes is supposed to be maturity onset. That was the definition. So you have it in people that are 40, 45 years above. But these days, we are seeing 18, 20-year-olds with type 2 diabetes. We are seeing myocardial infarction in 25-year-olds. So those are key things that we need to look at when we are designing these mHealth interventions. Thanks.
Thank you. I think I'll address two questions or comments that were raised. So when you look at the question around digital health solutions that we have creating demand, so focusing a lot on the demand side rather than on the supply side, I think we need to mention that there's a lot going on also on the supply side, where, for example, you have many pharmaceutical companies, engaging in an access to medicine, projects, and most of them, for example, work with Amref in the countries that we are in. And so once we create demand at the community level, then you're also ensuring that when that person who's diagnosed with any NCD goes to the facility, there's actually medication available for them. And so it's a two-pronged approach where you're actually looking at both the supply side as well as the demand side. And then the other thing is looking at also the new concept that's coming around strategic purchasing, where you actually are helping governments to then predict what their needs are where NCDs are concerned. And so, in cases where you have an essential, list of medicines that's supplied to all facilities, whether or not that's what they require, that changes to becoming what is the need in a particular facility, in a particular community, and therefore ensuring that the government purchases in that way. And of course, strategic purchasing in other areas like equipment, where if you need diagnosis or even treatment for cancer, then you actually have different models of financing that as compared to just buying. So you have leasing and other forms of purchasing. And then What we've learned as Amref in terms of scalability, of course, technology scalability is important, but also the value of partnerships and leveraging on existing infrastructure that has been used in other sectors. And so as Amref, for example, our LEAP platform leverages on existing telecommunication infrastructure. And so anywhere you have a mobile technology, then you can run the program where you train the community health workers using text and interactive voice recording. And so I think it's important to leverage on partnerships and existing infrastructure so that you don't have to build when you go into new markets or when you need to scale the innovations that you have. Thank you.
Thank you. I'm going to address myself to two questions. The cost of acquisition and the question that was raised by the gentleman sitting here about non-communicable disease and communicable diseases like HIV and AIDS. This is where ICT becomes very key, because ICT begins to do things that the human mind of the doctor cannot do or cope with. Our application, for instance, we are now able to, if we're to run all of you through that application, we are able to tell who is most likely to become diabetic and quantify it, and on who's most likely to become hypertensive and quantify it, and what needs to be done to push that back and give you what is required to push it back, and what is actually driving it. We'll give you the list of the things that are driving it, and those lists will be per individual. They're not generalized. And this, it's almost like artificial intelligence. Only a machine can learn and give you this, which is what we're looking for. In Africa, we don't know. You could get those statistics about NCDs, but there's a big avalanche that is sitting down there of people that are going to be hypertensive, are going to be diabetic. We don't know about them. Now we build applications that are actually able to mine those people, and now you have prevention that is targeted and it's highly scientific, and it's quantitative and qualitative. Yes. The second thing that you do, our application looks and learns from HIV. In HIV, by giving antiretrovirals early, it is a form of prevention, because when you suppress the viral load, I cannot infect other people. Now with NCDs, there's a big problem. She spoke about amputation. It doesn't matter who you are, where you are in America or anywhere. Once you've got diabetic, you are in for a heart attack. You are in for blindness. You are in for an amputation. You are in for kidney failure. Otherwise, people would not be having attacks in America and in Europe. You're in for those things. And then there are things that actually drive that. Now, our application, we take all of you again and say, who's most likely to have a heart attack? This one and that one. Who's most likely to have what is called coronary artery, atherosclerotic artery disease? Is this one and that one? And then we'll quantify it and qualify it. The human mind cannot do that. So we innovate for that, to say to the machine, tell us what is our risk, what are we in for? And out of that, we are able to plan. Okay, and that, with that, the machine is now able to integrate HIV, and you know, people don't become diabetic, and then when they become HIV, they stop being diabetic. They become diabetic and HIV and pregnant and have TB in one person. Now the machine can triangulate this person and say to the doctor, this is what you're dealing with. Don't give this medicine because of that. Give this because of that, and stop that because of that, and don't do. So a machine can be able to do that. Although I have that knowledge as a medical doctor, but I cannot connect the dots. I will have it, but will not be able to connect it when I'm facing you. That is why when you go to a hospital in America, you get into a hospital, you're seen by a cardiologist, you're seen by a neurologist, you're seen by a nephrologist, because one person cannot triangulate you and look at you as one. The applications that we've built looks at you as one. Pregnant, diabetic, hypertensive, and has got HIV and AIDS and has got TB. It understands this animal and deals with it. Now that gives you you see, you got to look at it this way. In South Africa today, you might say Africa does not have that, but prevention is better than cure. It's coming. In South Africa, when I qualified, diabetes was a disease of the Indians. Africans never had diabetes. But today, diabetes is the second killer in South Africa, second to TB. Okay, it's already raining. When the clouds were gathering, we were saying we don't have the problem, but now it's raining. Now, look at that and look at cost of acquisition. What is the cost of life? Now, I'm an entrepreneur. I innovate with the understanding that applications must be affordable, accessible, rapidly scalable, and acquisition should be easy. When I give it to you, it makes it easy for you to acquire it. But like anything else, if I give you a car and I say, but when you bring it for me maintenance, you must pay. You can't say, no, but it's not free. I give you a car for free. But in terms of maintaining it, I need to maintain it because it's high impact clinical knowledge. Okay? Now, look at it this way. We costed it for one province in South Africa. It cost the salary of one doctor will support the whole province. There's a huge return on investment, but it's not only supporting one province, it's supporting one province at a high level, where we're looking at outcomes. So it's not only coverage, it's coverage, equity, and quality, and effectiveness of coverage. You can't just talk about coverage. You're covering me, but I've got a kidney disease, and I die from a heart attack, but you're saying you've been covering me. What was the quality of your coverage? Because in your coverage, you could not tell that I was going to have a heart attack, and what drives that, so that you can stop it. I'll stop it there. Thank you.
I couldn't agree more. Thanks very much. Thanks for being so engaged. And for me, it was worth the trip already just getting to know you. Really, this is exact. For me, in an era of SDGs, vertical disease interventions are almost cynical. It's exactly what you mentioned. People present with different forms of morbidity, and they are one person, and they require one contact partner and one overarching interventional support with digital tools, for example. And thanks very much also for the lady mentioning the 854 program in Rwanda. I definitely want to connect and learn more and understand more. To the point on the total cost of the intervention and the sustainability of business models, that's actually close to my heart. And let me tease you a little bit before we dance, Frazia. When you say pharma companies engage in access to medicine projects and support those. For me, naturally, a project has a definite beginning and an end when the project is finished. The NCDs will never be finished. So the business model mindset is exactly reflecting that the private sector must not continue to engage in the usual partnership model. Here's a grant, you implement, and we report, we all feel good. It's about really leaving the comfort zone. If a 14-year-old person goes to the dancing class, believe me, this is very much leaving the comfort zone. And leaving that comfort zone means to accept that regardless where you are in the world and where do you want to do business, you need to do business in a responsible, sustainable manner. And it's about finding those new business models and new forms of partnerships where you can actually learn from each other and co-create something which then stands for itself and can live on for itself. Thanks. Time's up for... Yeah.
Time's up, but I need to say this. Kenya has got 1 million people requiring dialysis and requiring kidney transplant. Is that so? From diabetes, 1 million people. That is not doable. They're just going to finish the fiscus. But with our application, we're able to know each and every diabetic, each and every hypertensive, who amongst them is going to have this kidney problem before he costs us a dialysis and what's costing it. And that's huge in terms of return on investment.
Thank you also for me for all this. So I'll try to be quick because I think our time's been up for a while, but we just have too many passionate people on this panel. So very quickly, to rebound a little bit on what you're saying, you know, the irony is that digital health, if you think about it, is the one tool that can finally get us to do a patient-centric kind of model. I mean, think about some of the things that were said today. I really believe we're getting there. It's taken a while. The life cycle of digital health, unfortunately, you know, we mentioned the word pilotitis, huge amount of fragmentation. If I give you Mali, for example, 10 different maternal health, mobile health projects, none of them run on the same standard, none of them connect to the standard of the health agency. I mean, it's total chaos out there. But, you know, and we had this session also yesterday, ITU and WHO about to release a report on a common digital health platform. Everybody's learning along the way, we're getting there. And this is to answer also the question on the cost, because once we get that common digital health platform, believe me, investments will be much more efficient. Instead of having 20 platforms in a country already, you'll be saving so much money. And we are getting there. It's gonna take us a while. It won't be tomorrow that it'll happen. But truly, I think the people working on this are getting there. And then there's a lot of other things I could say about cost, but again, I'll keep it short. On creating the demand, which is a very interesting question, there's one little point that I'd like to make. You know, from early on, my interest lied really in LMICs. And we all know the mobile banking and the mobile payments story here in Africa. Africa is leading the world on this. Why? Well, it started in Kenya. 80% of people in Kenya were unbanked, okay? I've always believed the same thing was gonna happen with mobile health. And in fact, in 2013, PwC and I think it was GSMA published a report that showed with statistics that the adoption of mobile health was much higher in emerging countries than it was in industrialized countries. So unfortunately, this is why I was asking yesterday also to WHO, do you have statistics? And we don't have hard facts and numbers, unfortunately, on this to sort of prove this point, but I really, really believe in the capability of the adoption of being extremely high in Africa. That being said, on a pragmatic side, when you are building a project, doing partnerships with mobile operators who basically have a reach to the entire population, and if they're a partner of yours, they can send a message saying, hey, there's a new service, you can opt in, you know, that's a strategy. Patient association, if we go back to the Senegal mobile diabetes project, we worked very closely with them, so patients were being registered through the multitude of patient association, because it's very powerful in Senegal. They have centers all over the country. So that's a way. I'm just giving you tactics. Of course, it depends completely what you're reaching. But again, it goes back to the notion of partnerships. The more collective impact, I mean, the more partners you'll have, the more collective impact you'll reach. And connection to the government health system is essential. We were exploring here in Rwanda, you know, and Babil was speaking, you know, some of you may be familiar with Babylon, who expanded now to 2 million patients registered on their telemedicine platform here in Rwanda. The reason? Government's strong partnership, but also a partnership with the health insurance system. And they had to completely adjust the model which originated in the UK to the health system here with the triage system that happens at the health centers with nurses versus, you know, so in each country you have to adapt on how your distribution channel is going to be. Thank you.
Okay. Thank you very much. You made my task very easy because I didn't have to speak to do anything, basically. I have a very passionate speakers. We are half an hour more than expected, so that's great. So I really would like to thank you and thank you as participants to stay half an hour more, but I'm sure that the discussion will have to continue later on. And I think what you have said, it's quite interesting to say that while NCD are specific and requires a change in the health sector, digital tools can really help the health sector to address those NCD tools. And thank you, Dr. Sepula, because you really highlighted the return on investment is huge, potentially. And this justifies the investment, and this justified also and creates a lot of opportunities for sustainable business models like the one that you have been trialing for in Novartis. So I think we are very close to be there. If we also add the artificial intelligence, which is coming, I think the impact could be even much higher. So I hope in maybe 2-3 years we'll come and say, guys, we are very close to reach the 2030 target. So that let's hope about that. And thank you very much for your attention, and have a very good end of the day. Thank you.